Good evening, everyone, and welcome to week 6 of our PRI Breathing Mechanics in COVID Times webinar. It's always great to see all the familiar faces on each week, so we really appreciate you joining us, and I think you will look forward to tonight's discussion on abdominals, so it should be a good discussion tonight.
Okay. Hey, welcome everybody. Thank you for coming and thank you for being here. I'm looking forward to an hour with you on a subject that is in a series of discussions, if you will, and we're going to review where we're at in the series of this webinar here in a few minutes. I think we're like the 4th or 5th slide, but Jen's right. We're going to talk about abdominals, and if you remember last week, we talked about obstruction. And restriction would be a good word, but overall inability to move air comfortably because of a number of factors. We've been leading up to this night for a number of weeks. And if there's one piece of anatomy that we have that can really regulate our physiology, regulate our sense of inspiration, which will be something we're going to talk more about in the last 2 or 3 segments of this webinar. Our mechanoreceptivity to movement and how it interplays with who we are, both behaviorally as psychological people thinking and as people that have to manage things that we do operationally in our life that has to do something with breath and breathing. It would be these abdominals. It would be these internal and external obliques. Now, I could talk, and you could too, all of you out there probably could talk a lot about breaking up abdominals a lot more so than I'm going to in an hour. They're categorically 2 sets of them. We have a left side and a right side. We're going to talk about 2 sets of them this evening. But universally, they act and react around what we would call rotation. So the best way to go about tonight's discussion is to single out those abdominals that are most responsible for internal and external rotation. And that's what we're going to do tonight. And we're going to relate it to breathing and breath, and how they work in terms of operationally moving airflow in and out of your lung. So keep that in mind. This is a discussion about breathing mechanics. That's what we're doing this for. So we're not looking at abdominals this evening as a core muscle. They are. We're not looking at them as a postural muscle. They are. We're looking at them tonight as related to the last few weeks with respect to how we flow inside of ourselves and how we flow with that air that we have inside of ourselves, how we flow with it and how it flows in us. So it's called rib airflow obstruction. The abdominal muscles compress the abdominal contents. That's what they do. They compress the abdominal contents, and pressure is important, as we all know. The chief responsibility of the muscles in the front of our body is to compress. We could argue that they rotate. We could argue that they laterally flex. We could argue that they even help assist with appendicular movement that's necessary in life for us to move around with. But really what they do is they compress the abdomen. And how they compress the abdominal contents determines what our passive length tension curves of our diaphragm are. We're going to talk not a lot, but we're going to talk somewhat about length tension curve of the diaphragm this evening. So how they compress our abdominal contents determines how the passive length tension curve is developed in 2 of your diaphragms. You got 2 of them. Lung volume that corresponds with abdominal pressure. We've talked about that in the past. And passive length tension of the abdominals, specifically the internal obliques and the transverse abdominals. And tonight, Jan, when I say the word, you type this up for me, you noticed this already. When I say the word internal obliques, I'm talking also about the transverse abdominals. I'm not going to tonight go over all the other intercostals. We are going to talk about intercostals in next week's presentation. But right now, we're not going to talk about the internal and external intercostals. We're not going to talk about the rectus abdominis. We're not going to talk about the transverse abdominis. We're going to talk about internal and external abdominal obliques. And if you notice on the title of this week's discussion, it says internal oblique abdominal influence on external rotated rib airflow. Airflow is reflective of rib rotation or orientation. So airflow in your body is a reflection of where are your ribs. We don't often think that way. We think of airflow as being something related to the pharynx, or maybe the larynx, or the oropharyngeal cavity, or the tongue, or your neck. It's all that, or a zone of apposition, or a zone of opposition. But really what it's a reflection of is, if you want to get down to the osseous concept, it's a reflection of where are the rotations of your ribs. Are the ribs upwardly rotated or downwardly rotated? We're not going to get into superior T4 issues tonight, Jen. We're not going to talk about all the ribs in the chest wall. We're going to talk about those in the lower half of your rib cage. So when you say the word internal rotation or external rotation, we know that there's abdominal muscles that correspond with that rotation, internal obliques, external obliques. So let's just kind of keep that in mind and how it relates to this evening's discussion. Our pattern of chest wall compliance, this is quite a lengthy list because we've talked about all these, so I'm going to review a few things. Our pattern of chest wall compliance, our alveolar airway function, our lung arterialization, our pulmonary drainage of fluid, the amount of lung dead space, the pleural cavity negative pressure, the levels of CO2, and the chronicity of obstruction lung dysfunction are all subjects we have covered over the last 5 weeks. The last 5 weeks, we've covered all of those 5 subjects. All of those 5 subjects are going to relate to tonight and the last few webinar discussions. And tonight, we're going to influence all of those by the ability or inability to integrate our left internal obliques with our right external obliques during one phase of the breath called inhalation. Everything that we've talked about in the last few weeks is going to be related tonight to, are you internally rotating your rib cage or externally rotating the ribs in your rib cage during inhalation? Now, as a movement specialist, this evening should be fairly practical, fairly important, and fairly understandable, because that's what you do for a living. I would assume that. But yet all those other people and disciplines out there that are related to the other areas that I just went over the last 5 weeks are going to be therefore interested in this evening's discussion on how it relates to actual mechanical movement. I didn't say mechanical ventilation, mechanical perfusion. I said actual movement of a rib cage, and a rib that is in between attachments of abdominals and the diaphragm. So the lower rib cage is this anatomical subject that's between the attachment of the diaphragm and the attachment of the ribs at that area. So it's kind of a significant concept, because all of our movement, when it comes to breathing and our postural movement especially, has to go through that particular area of your body for you to breathe correctly during the activity you're doing, because the activity you're doing is going to have some IO and some EO, more than likely, involvement. I can't imagine when it would not. When it does not have any involvement, I know you're not breathing correctly, and so do you. Your length tension ratios are going to be off. Your tension in general is going to be high, and your ability to mechanically move with ease is going to be very difficult. So that's kind of an overall summary of what we've done in the past and what we need to do now, tonight. I like this slide, Jen. The reason I like this slide is because you're looking at a length tension curve. of a single muscle fiber. Let's just call it a one little teeny muscle fiber. And when you have that single little muscle fiber and you look at the length of that muscle fiber in terms of how long it is and in terms of where it's at in what it's doing, the length of it. If you look at the resting length, when it's just sitting there between two odds, two bookends, a right one and a left one. Let's call one a rib, okay? And let's call the other one an iliac crest. Well, that would be an abdominal single muscle. Or it could be, let's call one a rib and the other one the back of your spine. Well, that would be your diaphragm. Well, let's do this. How about if we go from the iliac crest all the way to the back of your spine? That's one muscle called rib muscle, called abdominal and diaphragm. That's rib muscle. So from the iliac crest all the way to the back of your spine, if you had one single muscle fiber composed of diaphragm muscle and abdominal muscle, one single muscle fiber, it would also have a length tension curve relationship. And that length tension curve, the tension's going to go up or it's going to go down depending on where that muscle fiber is with respect to the attachment sites, as that diagram will show you. So the further you get away from that length of that middle of that diaphragm, let's just call the middle of the diaphragm right by the spine. The middle of that diaphragm distance from one end to the other will dictate the tension that's going on with that muscle. So the resting length, if you look at the tension, it's going to be very, very high in the middle. But as you get closer to one end, the tension starts to do what, everybody? Drop. Well, that particular length tension muscle discussion that we just had, a unit of a single muscle, one little muscle composed of diaphragm and abdominal muscle, one muscle, we'll call it the abdominal diaphragm muscle, could be drawn out like this. This is your right rib cage. This is your left rib cage. There's the spine. And if you take that spine that you're centered around and put it in a resting position, and then you move your body one direction or the other direction around that spine, muscle tension's going to change in that muscle unit, multiplied by many, many muscle sarcomeres, many units. So what you're seeing on the screen, what you're seeing in the handout that you have, and what you see on the board are the same parabolas. They're the same type of things. This is called the diaphragm inside of your chest wall. I could take your chest wall, Jen, and I could put your chest wall here. And this could be the head up here. But there's your chest wall. Here's the left one, here's the right one. Humans have a tendency to like to turn their ribs in an external, this is kind of hard to draw, but if I drew up and around this rib, this line that is going from left to right is more externally rotating around that bell-shaped curve, and this one is internally rotating. So you got a rib that's going all the way through, and Jan, this one internally rotates as this one's what? Externally rotating. The length tension on both sides is going to go down on both sides if this body shifts one direction. So when I shift to my right, the length tension of my diaphragm and abdominal muscle, because they're all one unit, is going to go down. And when the length tension goes down, so does all the things the last 5 weeks. Something is going to happen in all those 5 things, because your ability to draw in air right now is going to be different. Your overall strength is going to be down because the tension went down. The tension is always going to be in a better resting state. The power is going to be if I can get this rib cage on this side to internally rotate a little more than it's doing, with this rib cage jet on this side, what? Externally rotating a little bit more than it's doing, so we can get a different situation. That situation would look like this. I'll take a red color. That situation would take and move everything more to this way. And if I move everything to this way, now the tension in that system is going to be balanced out better. Wow. It would be foolish to think that you're going to produce good length tension ratios of your two diaphragms without an internal and external abdominal oblique. That would be foolish to think that, because you don't move ribs just with your diaphragms, and you don't move ribs with your arms and your legs. We all move ribs by where we position ourselves for resting length tension. Here's the thing of the night you should remember. Humans don't want symmetrical resting length tension. In fact, we weren't even created for resting length tension to be on the same side. We want more tension with our middle of our axis over to the right more than the left. That's why our central tendon is so much bigger. That's where the length tension ratio is going to be most productive, because it's in a very ideal state compared to what you see on the left side. So our center of our mass is not necessarily in the center of your body. Those two central tendons have a leeway, have a lead in, and lead you with muscle tension through the diaphragm and the abdominal muscle, working together, co-contracting together to give you a better sense of power when you're on your right leg. The postural game is interesting to me because the postural game of life has to do with resting length tension curves. And length tension curves are fun to look at, especially if you like to look at physics. And I like this particular picture because it pretty much summarizes the operational need to keep our bodies expanding by the freedom to move with flexibility with balanced length tension. Our flexibility and all those things we talked about the last 5 weeks are challenged, all of them, your pH, your dead space, your alveolar perfusion, your ventilatory activity. If you go through every single webinar we've covered, all of that is going to be impacted if we don't talk about internal and external rotational activity as is associated with your spine, the middle of your body, your spine. This week, Jen, would you do me a favor? I forgot to get my water. Would you get a water bottle for me? Would you mind doing that? I'll just talk about this. I'll wait for you to get when you get back. This week, we are focusing on the need to keep the abdominal and diaphragm. I just went over that. Muscle length tension ratios balanced for good lung perfusion and ventilation. We're going to do that by, thank you, Jen, by reinforcing, thank you, simultaneously reinforcing directed and desirable expansion of the chest wall and associated lung volume with that chest wall through integration of left internal obliques. They have to shorten during inspiration. If you breathe in and your left internal obliques are not engaging because of poor length tension ratios, the things that we talked about in the last few weeks and the things we're going to talk about in the next few weeks are going to be all affected by that decision. We should try everything we can possibly do to isolate our internal rotation on the left side during inhalation, not during exhalation, during inhalation. Now look, we can't breathe in every time and internally rotate our lungs in a simultaneous sense of time. But we can do this. We can make sure we're prepared for wherever we are in life to breathe with a little opposition so our rib cage on the left side doesn't lose internal rotation capability. Because if you lose the internal rotation capability, your length tension ratio is now a memory. It's in your brain. It's in your mechanoreceptors receptivity. It's part of your proprioceptive, program. We're really being guided by rib length tension production. And rib length tension production puts us in harm's way, especially when we're trying to breathe in and we have no power provided by opposition to keep that left side in somewhat of a state of internal rotation. There is a degree that we all have When we lose a majority of our rib internal rotation, we lose our zones of apposition, we lose apical expansion, and we are then losing the floor because now we're a puller, as you all know. So, inhalation, inspiration goes hand in hand with internal rotation. And the isometric length tension curve, and I underlined it for you, represents the force a muscle's capable of generating while held at a series of discrete lengths. It's a force that's capable of being generated if it's held there at discrete lengths. We don't want to lose all of our internal rotation. We don't want to go to the end range and stay there. We have to have some ability to trombone, to move in and out of external rotation into internal rotation. And we do much better job of that, as you all know, on the right side. And sometimes we don't do a good job on either side, sometimes, as you all know. When tension, this is a discussion about tension tonight, at each length is plotted against the length. A relationship of tension to force capability can be predicted, as we just showed you. It's predictable. It's predictable if you're going to be winded. It's predictable if you're going to be stronger. It's predictable if you're going to be tighter, depending on that length tension ratio. And remember, the length tension ratio of our thoracic lumbar area, especially the lower lung area, is directed by that spine. Our spine's orientation is directed and directing the length tension ratios throughout your entire body. The spine was there for us to regulate that kind of length tension. What's going to be the group of muscles that's going to have the most direct impact of the entire body's length tension ratio? Abdominals and obliques. It's kind of important for us to remember that. It is not your piggy toes, it's not your hamstrings, it's not your arms, triceps, it's not your neck. What would it be? What's going to have the greatest amount of influence on your entire body's length tension of all the muscles in your body? Well, it would be the diaphragm and its corresponding muscle that's attached to it, called the abdominal wall, and specifically internal obliques, specifically, because the external obliques and the TAs, the transverse abdominals, and your intercostals, as you'll learn next week, are not responsible for that. Their compressive forces are going to generate different length tension ratios on your entire body. Now, before we get into it, you all know this. Your internal obliques on the left side work directly with your external obliques on the right side. But the external obliques are not going to do anything for your body's length tension ratio if their counterparts, i.e. the counterlateral, the other side of internal rotation, isn't there. So now we got another zone of apposition to think about, Jen. We've got this degree of need for us to balance out the ribs on one side and the other side with IO and EO balance. So I can keep myself, all my length tension ratio in my body more balanced by where I position my spine. So IOs discretely have to work with EOs. EOs are going to follow IOs. I didn't go the other way around. I'll show you the studies. It's not EO and IO, it's IO and EO. So force generated by a muscle is also a function of its velocity. How fast you move is going to be dependent on how easy it is for those ribs to rotate. Can you remember that? Our movement velocity is dependent upon how well our ribs can easily move in opposite directions around that spine. And what's going to hold up that velocity is how much length tension exists in the abdominal wall and the associated leaf I said that wrong, in the diaphragm and the associated leaf of abdominals. I didn't put the leaf tonight, Jen, on the diaphragm. I put the leaf tonight on the abdominals. It always cracks me up. We got two central tendons. We have two leaves of diaphragms. But did you know you got two leaves of abdominals? And those two leaves of abdominals are going to help you understand how to move with respect to speed. Your velocity of breathing when you need to become aerobic is going to be directly related to how well the leaf of your abdominals is going to superimpose some resistance to a diaphragm that's got to start working. And if those abdominals are not speed driven, Your diaphragm's going to work fast, but your abdominals are working slow. And next thing you know, there's no go. You're sucking air. And so keep in mind that your velocity of activity is a reflection on how well your left side of your abdominals, i.e. left internal obliques, work with the right EOs. The velocity of contraction of the human right hemidiaphragm, therefore, is higher on the right than the left. When you need speed, you're going to go higher degrees to the right because of this predictability, because of these length tension curve predictabilities. It's pretty easy to figure out what you're going to do when you want more speed. You'll generate more activity with your right IO and your left EO. That's speed. But when you want to go slow and methodical, you got to be able to move from side to side and rotate and do things with dependency on resting length tension ratios. Resting length tension ratios requires neutrality. Normal imbalance of tension between the two zones of apposition is neutrality. So it's a wonderful slide. It's a simple slide that says contraction and contractibility is a reflection of how well you're capable of moving in and out, side to side, on a resting state of a single muscle's length tension. But if you look at a single muscle's length tension by adding them all together, a bunch of toothpicks on top of each other, you're going to have a board. And if you add them all together in the muscles, you're going to have a nice, big polyarticular chain that all work together. And that tension in that big polyarticular chain is totally directed by the attachment of itself to a muscle that's going to be pulling in the opposite direction at the time of contraction. And that would be your internal obliques. And I'm always going to say internal obliques. I like this slide because this slide shows you muscle fiber length on one axis, the x-axis, and muscle fiber force on the y-axis. And if you look at fiber at optimal length, you're going to see good fiber force at the peak of that curve. The more you work away from that fiber's optimal length, the fiber becomes too long and your power goes down. So if the fiber is too short, your power is going to go down too. It looks like Mama Bear's got it again. And so what I asked Jen to do is to redraw this by not redrawing it, but let's redraw it by rewording it. So what she did is she crossed out the ascending limb and crossed out the descending limb. And we put instead, Jen, what'd you write down?
Internally rotated right ribs and externally rotated left ribs.
It looks like we're looking at this guy again, Jen, except we're going to get really classy now. We're going to go out there a little bit further with that black line. We'll take that line away. Because on this side, the ribs, the fibers what? To what, Jen?
Internally rotated.
Or the right side, right side. Fibers too short or internally rotated, you're correct. And what's going on the left side, Jen?
Externally rotated.
And that fiber's too what? Long. So man, we're seeing this in a lot of places other than PRI, Jen. We're seeing it in slides that say, you know, this is a fiber issue. You know, it's not a, 5G fiber issue. It's not an optic fiber issue. It's a tension fiber issue. You know, there really, Eric, in life isn't anything that's not tension. You know, tension's life. You either have it, not enough of it, too much of it, want to get rid of it, buy it, purchase it, sell it. You want tension. Don't we want tension? We all want some tension, otherwise we don't produce. The tension that you see on this particular screen she drew up, thank you for doing, by the way, Jen, that looks great, is this evening's discussion. I would like to get my fiber at its optimal length. I'd really like to get it at my optimal length. It has nothing to do with posture. It has nothing to do with balance. It has to do with how I feel. I want to feel less tension. And to feel less neurological, psychological, physiological less tension, I've got to make sure my fiber is not too long or not too short. It's that simple. And to get my fiber not too long and not too short, you better understand how to implement internal abdominal obliques, specifically as a human to a human on the left side. Otherwise, your ventilatory system, Your perfusion is going to know it. Your lung volume, your residual volumes, and there are a lot of them, it's coming up. Your functional residual volume, your tidal residual volume, all are going to be high because you can't get anything out. Things are too long on one side and too short on the other. Now, we as therapists and movement specialists start getting into mechanics and we start thinking, well, those ribs on that right side are all in one position. It's not even a rib cage discussion right now. It's a muscle discussion. As you're going to learn next week, there's lots of muscles between ribs. And in this case, tonight, we have one thing that's in between the muscle of the diaphragm and the muscle of the abdomen, a rib cage. It's not just one muscle, it's a rib cage. And that rib cage has got to internally rotate and externally rotate and externally rotate and internally rotate so that you can put your fibers at an optimal length anytime you want to with whatever you're doing. The co-contraction of the left internal abdominal obliques, or oblique abdominals, with the left anterior costal diaphragm will decrease the external rotation of the left anterior chest wall and correlated functional residual capacity, FRC. It will decrease it. So the contraction, that's a good thing. Put a smiley face. It's not a bad thing. The co-contraction of your left internal obliques with the left anterior costal diaphragm as a polyarticular chain will decrease the external rotation of the left anterior chest wall and correlated functional residual capacity. That is a good thing. That is power at rest without getting excited. That's efficiency of fuel use. That's expenditure of calories. That's sleep and rest. That's nasal flow. That's foot awareness. I could continue. That's good occlusion. That's good optokinetics. So that's a major important slide because we're talking about functional residual capacity. When functional residual capacity increases, you're sucking air. Your perfusion goes down. Your ventilation goes up. You're sucking air. You need more carbon. We had that talk 2 or 3 weeks ago. Co-contraction, and I didn't make a mistake here, of the left internal obliques. If you tell me you've got a person on a program and they're doing internal oblique work, I'd say that's great. But what's the ratio of the left to the right? That's what I'm interested in. Because if the ratio is slightly higher on the right side, I'm pretty sure it's going to be difficult for that individual to fully capture all the good things that are going to happen. If that ratio was a little higher, which side, everybody? The left. So it also enhances that left diaphragm leaflet's force for inspiratory pull to create desirable negative pleural pressure. We learned that was a positive thing. We want desirable negative pleural pressure. I can't keep track of these webinars, but go back and look at that webinar on negative pleural pressure. And it also helps us reduce airflow obstruction. That was last week. From left ribs that are too externally rotated when our gravitational pull in the body is over-lateralized to the right. It's a powerful slide. That means when we lateralize ourselves to the right, we have a very big difficult time on getting our body to internally rotate on the left. And so I put this slide back up. It was the one I used last week, Jen. And if you look at all the words in the slide this evening that say this one word, residual, write down the word, circle the word. I think they got this in their handout, right? That graph. Circle the word residual 3 times. Residual volume on the bottom, functional residual capacity, and residual volume on the bottom 3 times. Circle those 3 times. Residual volume on the bottom, RV, functional residual volume, FRC, and residual volume again. Residual volume. Residual volumes go up when you lose left internal obliques. When you lose right internal obliques, you're probably still going to have a little residual volume because of the central tendon has an organ called a liver underneath of it. The liver lives underneath your right central tendon. You're always going to have a little internal rotation on the right side because of that. God was a very intelligent creator. You're not going to die because you can't breathe without internal rotation, because you always are going to have some. You're always going to have a little bit of non-accumulated residualness on one side of your body because of it. But when you lose it on the left side, your residual volumes go up across the board on both sides. And so I'm throwing this back up. All the things we talked about in the past are all going to be influenced by the loss of that internal rotation on that left side. Sequentially, operation of these individual abdominal muscles needs to be modified, obviously, during inhalation to reduce the compensatory lower chest wall rotation to the left, facilitated by left external rib cage rotation and associated airflow obstruction last week at the right lateral chest wall and the left lower posterior chest wall. Another really operationally important slide. We're taking last week and we're looking at this week and we're saying this issue right here is going to sequentially is going to interfere with all your ability to drop off the word compensation in your life. Appendicular compensation is following this slide. When you see things that are legs flying out, arms flying in, you should probably, I would be thinking about this slide. It's associated with airflow obstruction. And more than likely, that airflow obstruction is related to the lack of internal oblique use. So when you look at pictures like this that we drew up in this, that we've had drawn up in this institute, we don't take it lightly. That chest wall on the right side is deflated because of this length tension ratio issue. We got this wonderful model now, Jen, and I love it. By the way, Jen, thank you. This is a good, I asked Jen, throw some slides in there with ribs, and Jen, this is a good one. Did you put the red arrows on for this webinar?
No.
So,
like that in the postural course.
is it really? I don't teach, Louise, I don't teach the postural course, but I love this, Louise. I love that. That's a powerful slide, isn't it? Because look at the ribs on the left side. They're flared out. Length tension is going to be an issue more so than not on that side. And the spine's orientation is to the left. The lower ribs are going to the left when that happens, which means the back of the spine is going to, Jen, the right. And when that happens, the length tension ratio in all the muscles of the body know it, because everything is in a twisted sequential state. If there is one muscle that's going to help your plantar fasciitis, if there's one muscle that's going to take away upper trap tension, Donna, what would it be? It's the left internal obliques. If there's one muscle that's going to help get through all that, it's going to be the internal obliques on the left side, because it sets the stage for velocity and power to get into a state where that overworked itis muscle can actually get a better length tension relationship for what it should be doing. So if there's one area of the body that really needs to be honed into, it would be that internal oblique. Well, here's what we do in this institute. We hone into that internal oblique, as you all know, for those people that are aware of the PRI that's listening to this webinar. So that's a wonderful slide. If you look at the inside transdental, if you look at the inside of the chest wall from the bottom up, you can see the volume of air on that left side that's not being exchanged. Look at the hugeness of that space. And that tension, remember that first picture of the slide, the first slide of this webinar? When that moves away from resting length states of rest, that power in that left lung is terrible. There's no negative pressure in that chest wall that can possibly begin to happen when that diaphragm contracts. Those lower fibers are already out there. There's no power left. So I really like these pictures, and Louise, I don't teach postural these days, and I look at that, I'm really glad you got that slide. The PRI techniques outlined in this presentation, along with the others that were discussed in preceding webinar presentations, will foster balanced length tension of biased, positionally placed muscle attachments that correspond with airways and arterializations association with right ground placement and positional security. Our respiratory muscle length tension ratios are developed and maintained by our memory of mass support. Wherever our brain feels we need support, whatever position that is, to handle the mass that you have on your body, the one muscle group that will do that for you is I didn't say all abdominals, is the diaphragm and its attached abdominal, are you ready for this? Leaflet. I didn't turn it around and say it's the abdominals and the diaphragm corresponding leaflet. As you're going to see, you have leaflets of abdominals on your muscle, and that allows your postural pleural passivity, which was, I think, week 1 or 2. Pleura needs to be passively allowed to move. The last 3 presentations in this webinar series will focus on how to maintain new paradigms of memory. Remember that I said that. New paradigms of memory. What can you do to keep this IO activity alive? What can you do to keep your pleural position alive, your spinal and rib cage rotational balance, and your sense of body weight, balanced body weight, on the ground as you shift from one side to the other side? Let's talk a little bit about oblique function. Let's start with the external obliques, Jen, tonight. Jen, how am I doing for time? Now that that lights up, we got about 15, 20 minutes left. Unilateral external oblique function. Let's go over this pretty fast. You have ipsilateral side flexion and contralateral trunk rotation from external obliques. You have increased intra-abdominal pressure. All abdominals give you increased intra-abdominal pressure. That's not exciting to me. More so on the ipsilateral side. But what's exciting to me is the external oblique function, when it contracts on that side, if it contracts on your right side, you'll get ipsilateral side flexion and contralateral trunk rotation. The right external oblique assists in maintaining intra-abdominal pressure in opposition to the contralateral internal obliques. External obliques on the right oppose contralateral activity on the left and the internal obliques. That's so important to remember. It's not like external obliques on the right, oppose the right diaphragm. External obliques on the right do oppose the right diaphragm, but more importantly, because of human nature, human construction opposes the left diaphragm contraction more because it's opposition to the left internal obliques. So your right external obliques are really opposing your left diaphragm more than it does the right diaphragm because of the internal obliques position that's going to be re-established when they contract. So based on the way we're built and the cooperation between those two muscles, if I want my left diaphragm to have more power and I want everything goodness that comes with it, I've got to isolate my right external obliques with my left internal obliques. Not my right external oblique with my left external oblique. My right external oblique with my left internal oblique will give me the power I need for my left diaphragm through the left abdominal leaflet, because the left abdominal leaflet is corresponding with the right external obliques. Contraction of the external oblique on the right without trunk rotation to the left will then, therefore, if you contract it, will stabilize the left internal obliques to become a better internal rotator of the lower left ribs during inhalation, which is just what I've been saying. So external obliques are really kind of big in my mind, only on the right side. If you tell me you work on external obliques on the left side and you're not cognizant of what it's going to do to your center of mass over the right side, that doesn't excite me. In fact, you're my problem. I got a big problem. I got somebody that's been put on a program that constantly keeps them over to one side because it's much more easy and much more powerful for you to get that function and that form, power, when you contract an external oblique on the left side and an internal oblique on the right side. This allows better expansion of the lung and rib cage at the left, mid-posterior, and lateral regions of your body, which is needed more than on the right side because of this asymmetrical function and form of each external oblique attachment. They're not in the same place. You know that. External obliques can't be in the same place. And each corresponding diaphragm, that's not in the same place to each side of the lower ribs. I had Matt today do this, Jen, right? What you've got is a picture of right external obliques. And the reason I had Matt take it off on the left side is because I want you all to appreciate those right external obliques are having a profound effect on the diaphragm leaflet on the left side. When I see right external obliques, I take all the other muscles off the chest. If I could, we would. We could have, if we had more time, Jen, we didn't. So if you look inside that chamber on that left side and you see that left diaphragm leaflet, you should immediately think that diaphragm leaflet's need for opposition through the left internal obliques is going to come from my right external oblique wall. That's the first thing I would think about. Because if you can think about that, you would do everything you can to get the right external oblique to work with the left internal oblique for operational length tension ratios that are desirable for power of all the things that we talked about the last 5 weeks. Now we're going to go into internal oblique function, unilateral internal oblique function. And I'm going over this fast, dirty, and quick. So I realize it's kind of quick. This particular oblique is responsible for lateral flexion of the trunk with trunk rotation to the same side, not trunk rotation to the other side. So this is kind of cool. This is going to give me lateral flexion, and compression to the same side with my trunk that's rotating to the same side. And that's kind of cool because when that happens, that increases my intra-abdominal pressure more so on the ipsilateral side. And it's a major mover of my left lower ribs into internal rotation, which is so necessary to preserve opposition and apposition to the costal fibers of the left hemidiaphragm. Opposition and apposition on the right side doesn't even worry me. But it worries me a lot on the right side if you didn't think about going to the left side first. If you go to the right side and work on things called opposition and apposition, and you forget about the left side, I'm pretty sure you're not getting IOs and EOs like you want. I'm pretty sure you're getting all IOs on the right side and all EOs on the left side. This internal rotation of the left lower ribs, are we doing okay, Jen? Yep. Secondary to both eccentric lengthening contraction and concentric shortening contraction, empowers simultaneous external rotational function on the right side. It's wonderful for me to know that anytime I would put you on a program, whether it's a PRI program or not, but if it's a PRI program, I'm pretty sure you're going to get your left internal obliques. And if you get your left internal obliques with that program, I'm fairly certain that the external rotation on that right side with those ribs are going to occur. Because external rotation of the ribs on the right allows for better overall lateral lung perfusion and lateral chest wall ventilation also on that side. So now I've got this wonderful expansion occurring again because of this cooperative activity going on between the IOs on internal rotation, primarily, Jen, on the left side. And so I asked Matt, do me a favor this morning. Would you just take the skeleton and throw the IOs only in on the left side and remind everybody that when you see the IOs on the left side, you should be thinking right diaphragm expansion. You should think that right diaphragm is going to do on that right side, expand, enlarge, get bigger. The liver underneath is going to say, thank you. You gave me some space. I don't have to hold this animal up all my life. Thank you very much. I appreciate that very, very much. And by the way, the ground over here feels a little lighter. Thank you. I really appreciate that. Hang in there with me. Don't let me go. Hold on to me. And that's what I see when I think of left internal obliques. And then what we should think about is that the left internal oblique and the right external oblique contract as the torso flexes and rotates to bring the right shoulder towards the left hip. That's not a bad thing. That's a wonderful thing. But when the right shoulder goes to the left hip because these ribs are way up in the air and there's nothing underneath of them, that's a bad thing. That's false rotation. This is good rotation. This is desirable rotation. If the right external oblique operates without simultaneous contraction from the left internal oblique, the trunk flexion is lost. And right shoulder will move forward to the left on a straight or extended spine. The spine is now too straight. The length tension ratio wants it straight. And as you're staying straight, everything is going to be now drifting over to that left side. This greatly reduces lung function and contributes to positive. I said positive. We don't want to hear positive. Positive pleural pressure. Nobody in this chat room right now wants positive pleural pressure. Or increase residual stuff, we went over that a few minutes ago, or hyperinflation 3 weeks ago, or alkalinity 2 weeks ago, or airflow obstruction last week. We wouldn't want any of that. So this week, if you really want to do something with ventilatory activity, whether you have COVID or not, you've got to be mindful of the left internal obliques. I love this picture, Jen. You know I do. You have a great schematic view, an illustration of external obliques on the right side, blending all the way over to the internal obliques on the left side. That's your corset novel life goal. That's what we are trying to do in this institute. That's the direction that this rib cage needs for better lung function. That's the title of this, Breathing Mechanics in COVID Times. That picture would probably keep a lot of people out of the hospital and get a lot of people out of the hospital if they're having a tough time ventilating perfusion. That particular picture. I'm giving you a couple of techniques tonight to get that. That's the specific thing that we need. That's why I wanted to do this seminar, right? That's why we wanted to do this webinar, for that particular reason. The balance between the insertion force of the IOs and the EOs on the anterior lower diaphragm is imperative to be effective. Otherwise, you can't deflate your rib cage. You'll increase abdominal pressure for postural regulation, or to inflate the lower rib cage for perfusion. Insertional forces provided by the abdominal muscles will depend on 3 variables related to respiration, as we summarize this talk. Number 1, tension, the first part of this talk, developed in the diaphragm muscle fibers during lateral dorsal flexion is a must. You need good tension. We all need good tension. Not bad tension, good tension. Orientation, another word, of the diaphragm muscle fibers, huge. Orientation of the diaphragm muscle fibers is best controlled, best gotten by internal obliques, not TAs, not erectus, not intercostals, which we're going to talk about next week. They have a whole nother responsibility. But the main reason for this discussion tonight is to reorient that diaphragm's position on the left side. And the distance between the side of the diaphragm muscle insertion on the ribs to the center of that spine. Because the center of that spine to those ribs have different distances. And when those distances increase or go down, optimal length tension power is lost on both ends. Optimal length tension is going to be realized when this comes closer through IR and this goes further through ER. That's resting. That spine will flex and rotate. This spine is going to extend and derotate. So those 3 things, our internal obliques, especially on the left side of our body, provides the necessary tension and the necessary vector on the lower ribs to lower them, so that the ipsilateral diaphragm can maintain the necessary distance from the center of rotation of the ribs on the spine for efficient and effective pull from the diaphragm during inhalation. Internal obliques and external obliques work with inhalation, exhalation, as you all know. You need external obliques on one side for inhalation on both sides. You need internal rotation or internal obliques on one side for inhalation on both sides. But to get inhalation on both sides where you need it for normal rest tension, you definitely have to increase the ratio of activity of left IO to right EO, then right IO to left EO. You have to be mindful of that. Otherwise, inhalation on both sides is not going to be the quality or the amount that you desire. Two techniques that will promote this with right external function for unobstructed, that was last week, for unobstructed lung function and reciprocal airflow in the human respiratory asymmetrically designed system are these two techniques. And I hope you enjoyed that. We're going to take I don't even know where we're at for time. We're not doing too bad. We're not too bad.
There's a couple slides with each of these, so we'll go ahead.
So Jen's going to read this. I'm going to take a drink of water. She's going to read this. She's going to read some of this, and then I got some things I want to talk about with each one of them, okay? These two techniques are for this webinar. These two techniques are things that I would ask you to think about when you think about left IO, specifically with abdominal compression and abdominal contraction for length tension balance, specifically for that. Okay, Jen?
You want me to read all the instructions?
I do, if you don't mind.
All four left posterior mediastinum expansion and left trunk rotation. Position yourself on your hands and knees with a 1-inch block or towel under your left hand. Maximally round your spine by arching your back upward as you roll your pelvis back so that your bottom tucks under you. As you inhale through your nose, gently press down with both arms as you attempt to fill your left upper back with air. Exhale and maintain this position. Hold this position while you take 4 to 5 deep breaths in through your nose and out through your mouth, attempting to fill or expand your left upper back with air upon each inhalation. Relax and repeat 4 more times.
Thanks, Jen. So Alex is on all fours in the first picture, and there's something under her left hand. And that 1-inch block or raised surface under that left hand, you're with me, right, Jen, on this, facilitates engagement of the left IOs through passive orientation of the upper torso to the left. Please underline that. Please think about that. And active stabilization in this particular position with that towel under her wrist from the right EOs. So I put her in a position of mindlessness. She doesn't even know what she's doing. There's a towel under her, and that little rotation is going to put her asymmetrical resting length tension ratios that reflect human asymmetrical ratios and balances the length tension ratio out for her without her doing anything. Isn't that nice, Louise? I didn't have to tell her to do anything. I just said, Alex, I'm going to have you put yourself in a position to put your diaphragm and your abdominal muscle on a spine that's going to be slightly over to the left to help you in other words, slightly not over to the right, but over to the left. She doesn't know this, but with that rotation, with that arm underneath of her, I'm going to engage her left side a little more, and she doesn't even know that. I've just displaced her off of her liver a little bit, just a little bit, and that small degree of movement with that towel under her hand is going to do what, Jen, to that length tension? Maximize it, balance it. Her right EOs are going to be more effective because of it.
The right EOs and the left IOs both rotate the trunk to the left, so you just positioned her in left trunk rotation.
Isn't that wonderful, Jen? Isn't that just a wonderful thing Jen just said? That's the message of the evening right there. I put her in a position. Now, from every breath from that point on, she's balancing out tension in her entire memory bank of her body, saying that leg tension now everywhere in my body is making a little less, it's a little easier for me to breathe, a little less difficult, a little more sense. By placing the hands and the arms and the shoulders in this position, and by arching the back upward, the left diaphragm becomes dependent. It becomes dependent. I said that again, it becomes dependent on the left IOs. The left diaphragm becomes dependent on the left IOs. I'm doing that intentionally. And therefore the right EOs, for the pull that's required by the left IOs and the left diaphragm to expand the back and the lateral side of the left chest wall, therefore, and that's called your left mediastinum, therefore and thereby reducing both lung and chest wall obstruction. So last week when we talked about chest wall obstruction, it's one of the best positions to get into and use your abdominal obliques to help get out of it. By positioning the left IOs in this position, the left lower ribs will not move out of internal rotation. And I would underline that. In that position, they can't lose all IR. They can't lose all IR. They're going to have some maintenance of IR when they stop breathing. If they would just hold their breath, which they won't. But if they were to stop, they're not going to lose it, just because they're not using it. They're not going to lose it. Really important. The next one's called the all four left posterior mediastinum expansion and left AFIR. Similar positions, but I'm still going to have Jen read this. Now, this is very, very, very similar. In fact, there's only a few words that are different between the two, and we'll tell you what the difference is in between these two exercises, techniques. Their differences are big, but the wording is hardly changed.
Position yourself on your hands and knees with a 1-inch towel under your left knee. Maximally round your spine by arching your back upward as you roll your pelvis back so that your bottom tucks under you. As you inhale through your nose, gently press down with both arms as you attempt to fill your left upper back with air. Exhale and maintain this position. Hold this position while you take 4 to 5 deep breaths in through your nose and out through your mouth, attempting to fill or expand your left upper back with air upon each inhalation. Relax and repeat 4 more times.
Thanks, Jen. So you can see, Alex, you got 4 pictures in front of you. And Jen just told you what she's doing with those 4. Now the knee is on a 2-inch block, right, Jen? Not the hand, the knee is. And the 1 or 2-inch towel that raised her surface of the left knee facilitates the engagement of her left IOs again through passive orientation of left lower torso to the left and active stabilization in this position from the right EOs. This enhances your right EO position. This is a good right EO technique. By tucking your bottom under your center of your mass, you'll move to the left and your right mid to low back will laterally flex. Think about that. That is a desirable thing. Your right EOs are the best tools you have to open up your right lateral back. Your right EOs can't open up your lateral back, your intercostals on the right side, as you're going to see next week. We'll talk more about it. If you don't have IO position first. We get you in an IO position on the left, your right EOs work, and next thing you know is not your left mid lower back's going to open up with inhalation, but Jen, your what? Your right lateral apical back is going to open. These 2 techniques were designed years ago for that reason. They're both very similar, but yet they're both very different because of length tension ratio relationships between the EO and the IO corresponding diaphragmatic activity. So the effects of breathing in or pulling in through your nose in this position will be the same as the former technique. However, this position gives that person a huge sense, and remember the word sense, that's what we're going to talk about next week, of the left IOs and abs in general. Because of the slight lengthening of the left IOs and because of the left IOs passive pull on the left lower rib cage prior to that inhalation phase of respiration. Upon inhalation, the right lower ribs will move more into right external rotation. This technique gets the right rib cage to externally rotate more than the other technique did. but it's still through operative activity from the left IOs with respect to the left because of the slight anterior positional lower right rib cage, pelvis, and hip. Guys, thanks so much. Thanks for being here. Next week, Jen, what are we going to talk about?
Maximizing mechanical reciprocal respiration force through the integration of intercostals, wrist extensors, and ankle dorsiflexors.
And I am looking forward to that talk, to be honest with you. Are there any questions by anybody tonight?
No,
Okay.
I don't have any questions.
All right.
So thank you again for joining us. I think this was I think Ron hit a home run tonight. It was a great webinar and really emphasized the importance of those left IOs working in conjunction with those right EOs. And the only thing I was going to say, these two techniques are very feed forward activating techniques. They're very simple to do. If you put them in the position that it shows, you really can't mess up very easily. Like it's a pretty feed forward activation techniques.
Yep.
So have a great night and thanks for joining us, and we will see you all next week.
Good seeing all of you. Thank you. See you next week.